We have to understand that what is success in this area is for children to be in school, for them to be sleeping, for them to be able to participate, for them to be happy. It's not weight loss. So it's how do we boost their health?
Welcome to another episode of the HSE Talking Health and Wellbeing podcast. My name is Eamon Keogh. On this episode, we'll be discussing childhood obesity. When and where should parents seek help, and how best can they support children living with overweight and obesity? We will be sharing some tips and useful resources available for anyone who wants to know more. I'm delighted to be joined by Dr. Grace O'Malley, Clinical Lead of the Children's Health Ireland Child and Adolescent Complex Obesity Service. You're very welcome.
Thanks very much, Eamon.
Grace, just to start off with, can you tell us a little bit more what is meant by childhood obesity?
So the childhood bit, we relate to anyone under 18. So generally we consider pediatrics and adolescent health for people under 18. But obesity is where there's an excessive amount of fat tissue in the body and it's causing problems with health.
Okay.
So you may have a child who's large compared to other people their age, but they may have no health problems. So they wouldn't be given a diagnosis of obesity. But if their height and their weight was measured and they were checked on a growth chart, they might be considered to be living with overweight. But it's only when there's health complications do we give a diagnosis of obesity.
Okay. And how many children are affected by obesity?
So at the moment, globally, we have about 427 million children with overweight or obesity. In Ireland, we're looking at about 1 in 4 adolescents and 1 in 5 primary school children who'd have overweight or obesity. When we look specifically at obesity, we estimate that there's around 9% of children and adolescents with obesity. And if we think about the census figures, we're talking about 80,000, 90,000 children and adolescents. We also know from primary school children, about 1.8% have severe obesity or are estimated to have severe obesity. So that's about another 18,000 of that 80,000. So we're talking about big numbers, really. And, it doesn't really matter if people are a different shape. But the problem is at a population level, we know if you're very underweight that you may have more health problems. Yeah. And if you're living with, high levels of overweight or high levels of fat tissue in your body, it can cause problems in childhood and then into adulthood, because we know there'll be a greater risk for many of these children for heart disease, stroke, type 2 diabetes and cancers.
Yeah, that affects a lot of children and also a lot of parents, I'm sure, who are listening to this episode. And you yourself work a lot with parents, but what would be the most common concerns parents would have?
So sometimes parents at this time of year particularly might be concerned about getting clothes that fit their child for the age they are. So buying school uniforms might be a bit of a challenge.
Yeah.
Parents might be concerned about levels of tiredness. If they think their child is very tired, they might worry about their child gaining weight faster than they see their peers or their siblings. So often we'll have families where one child is gaining weight at a fast level compared to their siblings, and the parent's quite worried about that. Some parents are worried because they themselves may have been dealing with obesity for many years themselves, or maybe type 2 diabetes or heart disease. And they're concerned about their child developing that and how they manage that. Other parents may be concerned that their child has come to them and made comments about not liking their body, which unfortunately we actually hear in quite young children, which is really concerning to be in a situation like that where children are thinking about themselves in that way.
Yeah.
Also, we might have children who report to their parents that they're being teased or bullied because of what they look like. And then sometimes children as well might be reporting pain or breathlessness. Sometimes a parent may not see that their child may have breathing difficulties or, not be running as easily as their peers, but other people might see, like a teacher or a coach. That can be quite upsetting for a parent if someone else makes a comment about how their child looks or functions.
Yeah.
It's a real mixed bag. And the first step is that parents are trying to figure out, well, do I need to do anything about this? Is there a problem? Do I need to look for help? Where do I go? And what do I do? What do I say? So often the key thing would be to ask yourself, well, are they able to do everything else that their peers can do? Are they able to participate? And if they're not, or if something's affecting their sleep, then it is good to look for support from health professionals.
I mean, even raising that as a parent with your child. So you might observe it, just trying to raise that as a topic is quite daunting for parents. Would you have any advice to parents on how to raise it?
Yeah. I think the first question is, do you need to raise it?
Okay.
So depending on the age of the child, you may need to say absolutely nothing. You may need to call out, though. Sometimes siblings may use language that's not helpful. Sometimes other parents or yourself, you might use language with your child that's not helpful. So whether that's, parents themselves speaking about their body in a certain way within earshot of the children, whether it's one parent commenting on the body of another parent or someone else they see on television, that's not particularly helpful usually. Or it might be siblings that are slagging one of the children because they maybe have a thinner body or maybe a larger body. So things like that need to be called out in the home.
Yeah.
It's not helpful. Words can hurt and they can harm. And then if you're thinking, okay, well, now I actually do have concerns and I want to do something about it, then the next port of call is, first of all, might be checking, do you have a GP? So does the child have a GP? Anyone under 8 can access free GP services. So making an appointment with the GP to have growth measured and to have their health checked. Some parents mightn't be willing to do that yet. So they might want to do something themselves first, which might be to take the weight and height of their child at home and pop them into an online growth calculator. It's really important that parents realise that you don't use adult BMI calculators for children. So if you go to child websites, you'll be able to get the childhood one. So whether it's through the HSE or the NHS, both have calculators.
Is it okay to do that, or should you go to the GP?
If you're trying to just check something yourself, if you feel like you can measure the whole family for their height, see how tall everybody is and what weight they are and how they're growing, that's okay to do yourself. Wouldn't get into that on a weekly situation or a monthly situation. This would be for a once-off, just to get a sense of where things are. If BMI, body mass index, is calculated and it seems to be in an overweight or obesity range, then it would be useful to make an appointment with your GP. Otherwise, don't do it at home yourselves at all and make an appointment with your GP. If you don't know the GP, it's useful to maybe send an email to the practice or call up and just explain that you want to bring them for growth measurement and health check, that you're a little bit concerned about how it might be spoken about because you want it to be dealt with sensitively. GPs have fantastic training and having difficult conversations, so they're used to that. But sometimes parents will be very worried about how this topic is addressed. So making contact with the GP is a good idea, and just letting them know that you're going to bring them in for this reason, because then the GP might decide to book them in at a certain time in the day when they have maybe a little bit more time, or at a time that's better for the child, maybe after school or whatever. The first step, though, will always be a growth measurement and then a health check. So you can't, as I mentioned, give a diagnosis of obesity without checking the health. So the child's breathing, their heart, their lungs, their movement, their development will all need to be checked by the GP. And then if there's problems with the child's health, then you might be thinking, okay, well, there may be a diagnosis of obesity, and how can we help? What can we do? Does the family want help? And depending on how that encounter goes, the family may decide, well, I'm okay at the moment. I don't want help at the moment. I might come back in 6 months, check how things are again. When we're looking at growth, we're always looking at change over time. So you don't base a decision based on one measurement. You're trying to see what's the pattern of growth like. So that's really important for people to understand. So you might look for having 2 to 3 measurements over time before you can really see what the growth path is like, or the trajectory, we call it. And sometimes children are actually moving down towards a more healthy weight, or they might be just plateauing off. I think it's really important for people to understand as well that children gain weight every year, and that's typical, that's normal. So we want children to gain weight every year. It's in and around between 2 and 4 kilos a year for boys and girls would be the average weight gain. For some children, they'll gain more some years, less other years. So sometimes parents are stuck in the idea of adult weight management, which we're not growing anymore. Adults, our height is stable. So our weight can either just go up or go down or stay stable. But height is changing for kids all the time. So we have to account for that. So that's why we use growth charts. It's always better to go to a health professional, but, some families may not have access to a GP, or they may find it hard to get the appointment when they want it, or they may have had a negative experience themselves because of their own weight. So that often we hear from some families can be problematic. If they've had a negative experience, they're much more reluctant in some ways to bring their child into that environment. But I suppose rest assured, this is a new emerging problem in the last 15 to 20 years. So health professionals are better than they were even 5 years ago. I would say that health professionals are much better trained than they were. You mentioned about raising the topic, and then you have to consider, well, do I speak to the child about this? And again, that depends on age and developmental stage. So you may have, a 6-year-old child who's already maybe having teasing in school because of how they look.
Yeah.
And on the one hand, you want to get it addressed, but the real problem is actually the teasing and the bullying. The child shouldn't have to change for that to change. So you have to obviously address this with the school, and that's a different set of kind of steps to take. But the child also should have access to healthcare in line with their rights as a child.
Yeah.
And we do know that if a child is carrying extra weight, they might have more health problems. So it's worthwhile getting that screening done. But you might focus it not on weight. You'll decide, I'm going to talk about growth, seeing how your growth is going, see if the height and weight are gaining at the same speed or is there one growing faster than the other. We might like to check your breathing, because sometimes I've noticed you're a bit breathless when you're playing sports or when you're out with your friends. Sometimes you're mentioning that your knees are a bit sore. I'd like to get them checked. Or your sleep. Sometimes you're not sleeping enough, and I think we need to just get that checked. So there's lots of ways around this from the child's perspective to address it sensitively while reaching your goal of bringing them to an appointment and getting checked.
I think what you were saying about talking to the GP in advance is very important as well, isn't it? It gives the GP the opportunity to tackle it sensibly.
Yeah, to prep for it, and especially for the age of the child. So generally a GP might have only 7 minutes to see somebody. Yeah. They're working incredibly hard. They're expected to see everything. And when you need these sensitive conversations, or doctor might decide, well, I'll only see the child for 5 minutes and then I'll speak to you afterwards, and the child can go out and play in the waiting room or whatever, depending on what the setup is in the clinic. But I think letting them know that this is what the reason is will be helpful for them to plan. Or they may decide, oh, well, there's somebody in the practice who particularly loves pediatrics or is very interested in this area, and then they'd book them at that. That can be useful.
Do you ever find from parents that they might feel awkward raising it, but actually when they do talk about it, because the child is being bullied or out of breath, so they have questions themselves, that it's nearly actually a relief for the child to be able to talk?
Usually that's the case. I mean, for some children, they'll have no problems.
Yeah.
And so coming to have a conversation, getting things checked and being told your health is great.
Yeah.
That's very important for that family, because when people make comments or if something's raised by a teacher, they can say, we've had him checked or her and everything's fine and we're doing fine, everything's okay. That's really important. For the kids where there is a problem, where their health is affected and they're holding on to this and they're worried about it and they're nervous about speaking about it, it's very difficult for those children. They can be holding on to a lot of pain and worry, and sometimes having that sensitive conversation is such a relief for them. And, I've had children as young as 5 who, when we've had this conversation sensitively in front of the child, they've said, oh,
wow,
I'm glad because no one will play with me, things like that, or I can't make friends, or whatever it might be in their words of how they're experiencing this. It's important not to have taboo, basically. Yeah. I think when you let sunshine into difficult corners, it disinfects things and allows things to just be released and to have an honest conversation. And often then you're trying to support the parent on how they can manage that and giving them the language to have just easy conversations about this. It's not something that has to be had every day, but when we talk about growth and health in our children, it should be an easy conversation. And it should be something that we're talking about all the time, in the sense of, what is our environment like? What's the school like? What's the school lunch like? Are there vending machines? All of these things we know have an impact on child health. Yeah. And we should all be talking about them all the time to make sure that we have the safest and healthiest environment for our kids. The older children, it can be much harder then, because they may have multiple health problems. And when kids come to our clinic, the first question we ask is, do you know why you're here? And that really allows us to plan how the next 30, 40 minutes is going to go, because even though these children and teenagers have been referred, so they've seen a GP, they've usually seen a general paediatrician, and then they've been referred to our specialty service. Some of them don't know why they've been referred because no one has actually had the conversation with them in a way that they understand. That's really important.
Yeah.
And often when you have the conversation, sometimes parents will be behind kind of saying, stop, don't mention. But, our duty of care is to the child. I mean, sometimes bring up difficult things, and that's what we're trained to do. And the duty of care is to the child. So even if it's difficult for a family, we have to address it. The onus is on us to learn how to do that properly and sensitively and respond to how the family culturally reacts as well. Because sometimes, certain words that we know from working with families and also from research, things like fat, heavy, obesity, those terms aren't very helpful terms in a clinical setting with families. They're not positive terms for them. But using terms like having a weight above a healthy level, I want you to be able to have as much fun and join in things in school as much as possible. And maybe you're not able to do that because of these issues like breathlessness or pain. So bringing it back to what the challenge might be for the child and how we can support that is the key thing, while also mentioning and highlighting their strengths. So the family's there together, the parents care about them, the parents are trying to support them, we're there for them. They don't have to come back if they don't want to. And usually when families hear that, they invariably at the end will say, no, I do want to come back. Especially teenagers, because often if you give them that choice, you say, we'll ask all of these questions today. We've loads of things to get through. But, at the end, if you don't want to come back, that's your decision. And we can talk about that at the end. And then usually at the end, 99% of the time, they'll say, oh, I think I will come back.
Yeah.
I think I can get something from it.
Yeah. Oh, that's great.
Yeah, well, that's a sign of success. So and that's the thing. We have to understand that what is success in this area is for children to be in school, for them to be sleeping, for them to be able to participate, for them to be happy. It's not weight loss. So it's how do we boost their health? We might maintain their weight and then they grow more. We may slow down their weight gain. So they may continue to gain a little bit of weight, but we're slowing that weight gain down. We might get some weight loss, but we're not looking for weight loss.
Yeah.
We're looking for their blood pressure to improve, their breathing to improve, their cholesterol to improve, their balance to improve, their fitness, their mental health, their mood.
I mean, that's the complexity of obesity, isn't it really, that it's linked to so many other different...
Yeah, because we've evolved throughout time to be able to store fat. And that's why you and I are here, because we've been able to do that as human beings.
Yeah.
But the challenge now when we're in an environment that promotes gaining fat, genetic superpower that we had to store fat isn't as necessarily helpful now because we're storing excessive amounts of fat and in places that we didn't store it before. So when we store this fat in different places or in a large amount, it affects every system in the body. Not every person will have the same manifestation of their obesity. So some children will have no problems with their cholesterol or their blood sugar, but they may have problems moving around. They may have joint pain. They may have muscle weakness, balance problems. Some children will have breathing problems. Some children will have maybe urinary incontinence and leaking. Yeah. Some may have sleep problems, and some may have all of those. So that's where a holistic assessment is really important, and a multidisciplinary team is really important. So being able to access a GP as the first entrance point is really important. And then being able to be signposted or referred to other services like dietetics, physiotherapy, occupational therapy, psychology is really important.
Okay. So that's how the system works, really. You refer to your GP and then depending on your needs.
Yeah, so the system should work in one way. It doesn't necessarily work in the way we want it to work, but we're still trying very hard to get it working properly. And we have huge limitations in terms of staffing and resources throughout pediatrics and adult care, but I'll focus on peds. So in general, you'd either, if you're, let's say, a little infant, you might go to your public health nurse. If there was a challenge around growth, whether it's underweight or overweight, then they'd refer to GP or maybe general pediatrician, depending on what the issue or the concern is. So then usually GP, ideally to HSE primary care services first, and then into general peds, unless there's an actual medical concern where you'd skip the other primary care services or be referred in tandem. Then general pediatrics will do a full pediatric review for the child or the adolescent, and then they'll either refer them back to primary care, dietetics or whatever other services they need, or they'll refer them to tertiary care. So that would be referring to CHI. So you'd see your GP in your local community, you'd see a general paediatrician in your local area, wherever that might be in the country. Then you'd be referred, if they have severe obesity, to Children's Health Ireland, and then we'd see them in our clinic and may or may not refer them then to endocrinology or respiratory medicine, depending on if there's other issues. We're trying to roll out multiple programs in paediatrics at the moment. So there's a model of care of paediatrics that's been implemented. We have the model of care for obesity, which has been implemented. We have progressing disability services, which has been rolled out. And we have changes within CAMS, so the child and adolescent mental health services. So all of these are being basically reformed.
Yeah.
And it's meaning that there's massive waiting lists. There's not enough staff. And then COVID came along and really obliterated a lot of that staffing as well. So many staff were redeployed to different areas. It meant that there was huge waiting list increases. And, we talk a lot about the impact of COVID on adult healthcare.
Yeah.
And because it didn't really affect children acutely, we didn't see, huge changes within pediatric acute healthcare.
Yeah.
But now we're really seeing the impact of COVID, I think, in terms of physical health and mental health. But we've never had, an injection of a funding package to try and remediate the problems that COVID caused.
Yeah.
So it's going to take years, I think, to get to a better place. But I think there's definitely a lot more interest within the health professional community in training themselves up, learning more about how to manage kids with obesity, and then how do we prevent as well. And then how do we use, innovative solutions? So how do we use digital care? How can we fill the gap of not enough health professionals and without training, and for the long-term care that these kids need? Because if you have a diagnosis of obesity, it's a chronic condition. Like if you have type 1 diabetes or cystic fibrosis, I think that's something that people don't really understand. So, you may have a child who has overweight and they may be able to manage their weight and maintain their weight as they grow into their height, and it'll return to kind of a healthier level. But if you have a diagnosis of obesity with lots of health complications, the reality is that they probably will be managing this for the rest of their life.
Yeah.
And that means that our health service really hasn't ever been prepared for this new chronic disease, and we need to respond. So the model of care for obesity has really done a great job at trying to set out a plan for how to respond to obesity. So we have a across the life course, from universal care services all the way up to bariatric surgery across the lifespan. And we're in the middle of implementing that. So we're getting there slowly, I would say. Implementation is underway, but we need to do a lot more, and we need kind of anybody who's able to vote, we need them to be advocating for funding the implementation of the model of care for obesity.
Right. And just, I suppose, going back to parents then, so, they visited their GP and maybe they're on a waiting list. What can they do in terms of supporting their child when they're waiting for an appointment?
Yeah. That's a challenge because it depends on what the situation the child is in. So regardless, there's still kind of key things that you can do. So I suppose the first thing is to look for, good quality advice and information. If you go onto the internet, you could see all sorts of stuff that won't be helpful. Yeah. So going to trusted websites like the HSE website or the NHS website in the UK as well can be very helpful. Other websites like childhoodobesity.ie. So this is an initiative between our service and CHI and my research team in CSI in the College of Surgeons. We've been funded by the Department of Health and the HSE to develop a training package for health professionals. So it's at childhoodobesity.ie, and on there's also resources for parents. So there's plenty of good information on that. Also going to the Department of Health websites where you can get the healthy eating guidelines for children under 4 and then the 5+ eating guidelines. And then kind of focusing on 10 key aspects, I would say, would be useful for families. So the job of childhood is to have fun. It actually is. And we've kind of lost that. So making sure that there is fun, that there's laughter, that children are building relationships with their peers, and understanding as well now how the online environment is a part of that for their social engagement with others. And so how to balance that. Getting enough nutritious food. So 3 healthy meals a day, 2 healthy snacks, and then the right size portions for that age, for that child. So that's where going onto those websites can be helpful. Drinking enough water. So between 1.5 and 2 litres a day of fluids. And kind of a nice way of figuring out whether your child's drinking enough is to look at the colour of their wee.
Right.
So check in the toilet. What is their wee like? Is it a light yellow colour or is it dark yellow? Is it light brown? If it's light brown, dark yellow, they need to be drinking more.
Yeah.
So make sure they're drinking enough, particularly in the morning and the afternoon. Really trying to increase fruit and veg into their eating pattern because it's really essential for their growth and their development, all the vitamins and minerals we get in fruit and vegetables. So we'd say at least 5 portions a day. And again, it's child portions. If you were trying to choose vegetables over fruit are more portable sometimes, but vegetables have probably less sugar and more fibre sometimes. So try and get both.
Yeah.
And try and not rely on just one type. Then active play and movement. So remember, children are developing their lungs, their bones, their muscle, their heart. They're not like adults. We formed all of our organs. So kids need movement to grow properly and to develop. So under 5 need about 3 hours a day. And that's in lots of little blocks.
Yeah.
If you're listening and you think 3 hours, my child's only getting about 10, 15 minutes of movement and they're a 4-year-old child, that's a problem. That's a problem for their heart and lungs and for their mental health as well, for their cognitive development. They need to be playing.
Yeah.
That's their job.
Yeah.
For kids over 5 to 18, then they need about an hour a day. And that's for health and development. So this is just at the basics to develop healthy children. For if you're struggling with weight or trying to, reduce fat tissue, then you may need more than that. But start off with trying to get the hour anyway. And then sitting, we know, is independently a problem for all of us. So trying to avoid sitting for more than 2 hours, breaking up. If you're sitting for 30 minutes, kids should try and get up and move, even for 5 minutes. And we know that already helps their blood pressure and their blood sugar, even just breaking up sittings. That's important. Tip number 8 now, for anyone who's not counting. So then getting enough sleep. So in primary school, they should be getting around 11 to 12 hours sleep in primary, and then for secondary, between 9 and 10. Ideally, that sleep should be at nighttime. For the teenagers who are kind of staying up really late and then sleeping late, you do need to try and figure out how do we pull that back and get them into bed early. And so screens, so it's really important to limit screen time to 1 to 2 hours per day, and then try and have no screen while you're eating or no screen while you're walking, or no screen while you're in bed. So trying to turn the screens off an hour before bed and keep them out of the room. Many children and teenagers will say, I need my phone for my alarm clock. So it's really useful to get a travel alarm, which you can get in most pound shops.
Right.
And get into the habit for the whole family, though, of putting the phones away at night. So parents have to practice what they preach. There's absolutely no point giving advice to your child and being a hypocrite. So you have to put your own phone away, get it away at nighttime, have a clock. And obviously there's times when you need your phone on during the night if there's family emergencies, that type of thing. Far less of us have landlines. So we understand that. But try and move the family towards getting the phones off at night. And then I think for parents as well, be really aware of advertising. So advertising is everywhere and it's very powerful and it works. So whether it's digital advertising or advertising that they're watching on television or in movies or even in comics or books that they're reading, you kind of have to be conscious of that. So mute the ads on TV, don't have the sound on, or record programs, fast forward through the ads. Even if you're online and there's ads, turn down the sound when they come on, because they're not for the foods that we want children to eat for their health. They're always for high energy dense, what I call edible products, that we can eat them. But I don't know if they constitute food personally when they don't really bring nourishment. So watch out for ads. Support one another as parents, speak to other parents, see how they've managed. And then unfortunately, because of the way our health system is at the moment with long waiting lists, do ring up and say, where are we on the waiting list?
So
it is important to do that. And it does indicate as well, like sometimes services will have cancellation lists.
Yeah.
And if a parent rings up and says, can you put me on a cancellation list? They may get an appointment faster, because we do throughout pediatrics have non-attendance rates of about 20%, if not more sometimes. So that's high. And that's for a very good reason. Sometimes people are sick. They can't get to appointments. Adults are sick. Their children are sick. But we really need to get that non-attendance rate down across all services as well. So parents need to work with the health service on that. So do add yourselves onto cancellation lists, especially if you live, not too far from the hospital or the clinic.
One thing I was going to say, sorry, that you said about the food environment and that it just struck me. Parents as well need to give themselves a break I think that sometimes parents blame themselves in certain situations, but it struck me, I was having a chat with Dr. Aileen McGloin in Safe Food about the food environment. She was talking about they did research with parents. What was very interesting, parents blamed themselves for, obviously the foods choices and that, but they didn't blame the supermarkets or the advertisers in terms of the exposure to unhealthy foods and the bombardment of, of those foods towards their children.
No, exactly. And it's everywhere. Yeah. And different countries have different regulations around, how marketing or advertising is restricted or reined in.
Yeah.
And different countries have different laws around planning and how they build housing and whether there's access for children to playgrounds or spaces to play. I think we all need to be a lot better at demanding that we have healthier environments for children, because we do know all of these environmental aspects affect obesity. It's not just personal choice or personal responsibility. We have a situation where there's a biological predisposition of some people more than others to gain fat tissue or to hold on to it. And then we have the biology of the system that when you do gain fat tissue, it's harder to lose it. And that's primal because of genetics. So our body tries to hold on to that. And then we now have this environmental aspect where the world we live in, and it depends where you live, obviously, but also in Ireland, it depends where you live. There's some neighbourhoods that are harder to live in than others, but it's obesogenic. So that means it promotes us gaining weight. So if you have people who have a predisposition who are now in an environment that pushes weight on them, literally, it's everybody's responsibility. It's not just that parent's responsibility. And it's certainly not the child's responsibility. And unfortunately, things are changing a little bit, but I'm working in this area 20 years and it's only recently changed that there wasn't an attitude that it's the child's fault that they've gained weight. And you wouldn't see that in any other area of child health. If a child had a skin disorder, you don't blame the child for that. Or if they've asthma because they live in a neighbourhood that has really high levels of air pollution, you don't blame the child for having a wheeze. But yet we have blamed children for their bodies reacting the way they should to this environment, and it's not acceptable.
Yeah. I was going to ask you if you thought there was a misunderstanding about childhood obesity out there still.
Yeah, I think generally humans are, we see things through our own lens. So if you're somebody who's never had pain, you don't really understand what it is to be somebody with pain, or if you've never struggled with your weight or had difficulty with your mental health, you don't understand what it is to have that. There is a judgment internally that we all make, I think. We're conditioned to almost think that other person, they should just do this or they should just do that. They should do what I do and they'll be grand. Yeah. We do that as humans. And I think over time there has been a lot of misunderstanding about the environmental impact on obesity and the biology. And we didn't know a lot of the biology because when I started in this area, it was very much energy in, energy out. And there's more energy in. So that means you develop overweight and you just need to reduce the calories, increase the expenditure, and you'll lose weight. Now, part of that is true. You can lose weight, but you won't necessarily maintain this. I'm talking about adults now. You could lose weight that way, but you won't maintain it because the body adapts to try and gain back that weight. That's why it's so important to address childhood obesity, because it actually gets harder as people age. The perception around, the parents being to blame is changing slowly. I think there might be more of an understanding after COVID about how easy it is to gain weight if your routine changes. Most people experienced something in COVID where when their routine changed or when their socializing changed or their food habits changed, that it actually had an impact on their health. And it was very easy for that to happen. And many people are probably trying to address that now still after, 2 years. I think people as well in COVID may have, I hope, will have started to reflect on, how lucky they were if they had a park or a playground to go to within their 5K. Many families didn't have that. So their children didn't have anywhere to go and play during COVID in that first initial place, the part when we were really restricted to 5 kilometres. So all of these aspects really impact on a child and how they grow and how their health develops. I mean, there's tons of research that looks at these socioeconomic drivers from the family level to the community to the whole society. But I think maybe the public perception has changed a little bit. I think there's a lot more families looking for help themselves, like coming forward. I think the voice of people living with obesity has become really strong. So the work of the Irish Coalition of People Living with Obesity has been immense. It's had a massive impact. And so parents, if they're listening and they're worried about, their own struggles with weight or obesity, they should look up icpo.ie and join, because they have weekly calls where you'll be speaking to people that understand, and that can be very helpful. I think as well that there's probably more of an understanding about how food affects us, and that when we commodify and commercialize food completely, that we lose something. So, our grandparents would have made homemade meals. Yeah. Probably all would have had access to a kitchen and a kitchen table. Many families now don't. Yeah. So we live in a very different environment in terms of food and the food environment. So I think those kind of public health aspects, people understand a little bit more. I think they also understand a little bit more about the big business of food and how it's pushed and how health is absolutely ignored. It's neglected because it's not good for a bottom line. No, big food companies do not care about the nutrition. So in general, as a rule of thumb, when we're speaking to some of the kids, if you see something advertised as healthy, or it has green packaging, or it has added this or added that, or, lovely packaging and branding that makes it look healthy, usually it's not, because they don't need to advertise that. Usually they'll advertise if they're adding things to foods that are not that helpful for us. Bit by bit, things are changing kind of on a public level. And then from a health professional point of view, there's a bit more of an understanding of the complexity and that we're not trained. So again, it's only emerged in the last 15, 20 years as a condition, childhood obesity. So most health professionals haven't been trained in their undergraduate courses. Many have had some postgraduate training, but not specific to childhood obesity. That's where our childhoodobesity.ie training course is so important. It provides free access to health professionals to do that. So any health professional listening and they a bit nervous about this area or don't feel like they are confident, they could do that course. Most health professionals have fantastic skills that they can transfer into this area, so that they may not feel competent, but I guarantee you they have skills that they'd be very useful. Then I think they need to advocate for undergraduate courses to, include more on obesity and childhood obesity. And then we all have to reflect really about bias and stigma, and are we judgmental towards people of a larger size? And I would say probably most of us are at the beginning when we reflect on this. We may not be aware of it, but you need to ask yourself, do you think differently about patients who are in larger bodies? Do you offer them different assessments? If you don't have a blood pressure cuff that's big enough, do you go and order a new blood pressure cuff, or do you say, oh, sorry, it's not big enough for you, and then you never measure blood pressure? And unfortunately, that happens a lot.
Yeah, and that wouldn't really happen if you had any other complaint.
No,
really,
it wouldn't. It would not happen. Yeah. So that has to change.
One of the other things that struck me, the language that's used by healthcare professionals. I mean, that's come up again.
Yeah.
Just been more
respectful. That's all. Yeah. And it can be so damaging for people, parents and patients who've engaged in services because of their obesity will tell us that the way they were spoken to meant they never went back to a health professional again because it was so demeaning, so shameful. Yeah. Or parents will report they felt that their child was verbally abused because of the way they were spoken to about their weight. And I mean, that to me is completely unacceptable and should be reported as a risk to those services. So if things like that have happened, you have to report it. It's not acceptable. So we do have to learn how to have respectful conversations, how to bring up the topic in a sensitive way, and then how to signpost people. If we can't do something ourselves as a health professional, depending on what discipline we are, we need to know how to signpost people to appropriate resources and then how to refer. And I think sometimes health professionals, we try and do everything and we try and want to take it on ourselves. It's just sometimes the nature of who we are. But we really need to understand that this topic in particular, you need to refer to other disciplines. So you could be the most accomplished GP in the world, but you still need to get the insight and the experience of a dietitian and a psychologist, maybe a physio if there's, movement problems or breathing difficulties. We need to lean on each other as disciplines so that we have proper multidisciplinary care.
Yeah.
So that's important.
And you talked about, I suppose, the attitude and just the learnings from healthcare professionals, but you're a senior lecturer in the School of Physiotherapy at our CSI. Do you find the attitudes changing of, say, medical students in this area?
Yeah, over time, I think things are changing slowly. Most undergraduate curricula don't have any training. So when you start to talk about the topic of obesity, sometimes there's a lot of misunderstanding that you have to counter. Sometimes can be an idea sometimes that if you talk about this, that you might create eating disorders, which I think if you talk about something sensitively, respectfully, and follow the evidence base, you won't create an eating disorder. And we know there's lots of evidence, particularly in children and adolescents, if you provide multi-component, multidisciplinary obesity treatment, you reduce the signs of disordered eating and eating disorders. I think for physio students, dietetics, nurses, all the disciplines, we need to change the curricula. We've managed in RCSI to change the undergraduate medical curricula so that there is childhood obesity covered as a mandatory topic. So that's fantastic, but every college needs to do that. And then we also need to address the hidden curricula. So that's where you might have all the wonderful evidence in their learning on paper. But if they go to clinical practice and patients are treated in a different way, this is what we call the hidden curricula, where there's this kind of culture of how people are treated. So attitudes, I think, yes, they are changing. It's taking time, but there still is a lot of stigma and discrimination. And some of our younger students coming up still have that. So we need to address it. And there's some great work being done by the Association for the Study of Obesity in the island of Ireland, along with colleagues from UCD in Galway and RCSI, looking at obesity education and how to address stigma for health professionals. So that's important. We're doing a project in RCSI as well around training communication in this area for health professionals. That'll be available soon. There are changes happening. We've more health professionals interested in the area, which is fantastic. But we do need whatever government is in power every cycle to take this seriously and to, commit funding to implement the model of care. It's really essential.
Yeah. Grace, I heard recently as well a certain narrative coming to the fore about that tackling childhood obesity is all about prevention, but the treatment side of things is also very important, isn't it?
Yeah, absolutely. So with any chronic issue, you have to prevent.
Yeah.
We have to treat and we have to care for people who have the condition. So similar to HIV, we started managing HIV by prevention. Then we understood, well, that's okay for population level, but we need to address the people who actually contracted the virus. So same with obesity. We have to have an environment that promotes healthy growth and development and that minimizes the risk of obesity. Then for those children who develop obesity and have health problems, they have a right under the UN Convention on the Rights of the Child to access healthcare. And we have to provide that healthcare. We know from the evidence base and clinical guidelines what that healthcare should look like. It needs to involve a multidisciplinary team. You need to have different treatments for different age groups and then for different severity of obesity. So we can have stage 1, stage 2, stage 3 obesity where there's problems, or you might have stage 0 obesity, which is kind of what we spoke about before, where there might be overweight but no health problems. And for the more severe obesities, we really need to then make sure that we provide access to other treatments. So whether they're medicines or bariatric surgery. People might be shocked to hear that. But for adolescents, if you have someone losing their sight because of their obesity, we have to prevent them losing their eyesight. And we have to do everything we can to do that. And that might mean surgery. And bariatric surgery for adolescents is an effective treatment, safe, but it's not done in isolation. You need the whole team around that adolescent for pre-op care and then for post-op care. The same with the use of medicines. While we may have some medicines that are available for adolescents now with obesity or certain types of obesity, they're not reimbursed. So you have to be able to pay for them. So we need reimbursement. And then for the people that are eligible for those medicines, they should never be used in isolation. So we can't get to a point actually where we say, this is a magic pill, this is what they need, and not offer them visits with a dietitian or a psychologist, physio, OT, to manage all the other aspects, because it's not just about their weight. An obesity medicine may, improve their health. It might reduce their weight. It might improve their cardiovascular profile, might improve their metabolic system or reduce their risk of diabetes. There's other aspects that the child is still affected by with their obesity. And the medicines may have side effects on how their muscles work. So sarcopenic obesity, you might develop weak muscles, or during childhood and adolescence, that's really important. That really affects bone. If you have weak muscles in adolescence, you're going to have weak bone, and we develop a bone bank during adolescence. And, at 14, 15 years of age, that's the maximum bone you'll ever have in your life.
Yeah.
And for long-term bone health, we have to make that as optimal as possible. So anything that interferes with that, whether it's too much sitting, whether it's too much caffeine or carbonated drinks, whether it's the use of steroids, whether it's the use of other medicines, we have to address it. So prevention is key, but treatment is a basic right. It's a human right. It's a child right. And then care in terms of how do we set up our health system to actually manage this in the long term is really important. We have to. It's going to take a lot of resources, a lot of passion and commitment, but we need our government and our policymakers to commit to implementing the model of care.
Yeah.
And we need our educational institutions to commit to educating their health professionals to be able to practice in today's world. Yeah. We're not in the world 50 years ago. And a lot of the curricula are based on, older conditions that maybe we don't see so much anymore. We need our community services to improve. At the moment, we've had investment in 2 community-based obesity services in CHO5, which is the Waterford area, CHO7, which is kind of Tala, Rathfarnham area. But every community health organisation or every region needs to have a primary care team that can work in paediatric obesity.
Yeah.
And then we also need our secondary care services. So all our general paediatric services around the country need to have investment to be able to manage this. And then we need full funding for the tertiary service in CHI. So there's work to do, but it's actually good value. Like if we do this properly and implement it, we can make a big difference.
Grace, we're coming to the end of the podcast, but I just wanted to ask you, are there any new areas that you're coming across that you'd like to see progressed? I mean, we've talked about the funding, we've talked about that integrated care approach, and also we're asking people to go out and raise it with their politicians when it's time to vote. But are there any new areas or initiatives that excite you you'd like to see progressed?
Yeah, I mean, I think the implementation of the model of care is key. So across primary care, secondary care, tertiary care, we need funding. Posts that were suppressed with the HSE embargo, they need to be reinstated. So that's an issue across services, particularly in paediatrics. And then how we use, I suppose, novel treatments. So how do we use digital care, telemedicine? Can that meet some of these gaps? So we have, big gaps in terms of availability of treatment for children with obesity and accessibility.
Yeah.
So some of the work that I've been involved in, I was funded by the Health Research Board and the Temple Street Foundation to undertake a PhD which focused on developing telemedical services as part of obesity treatment. And we had good results from our clinical trial. So we need to look at how do we get investment for that? How do we expand that service so that a GP down on Inishbofin can access a service that they know is trustworthy and reliable and evidence-based and built by people who are interested in the child, not in harvesting data.
Okay.
So how do we expand these services? And then also, how do we make sure that when we're increasing our use of medicines, that we do it safely and that we have health in all of our policies as well?
And just on that service, would that be that a GP could call somebody on and ask information?
Well, that was a Android app. So it was an application that the teenagers and their parents used. And then there was a clinician back end that you'd plan your treatment with them. So it was a full telemedical service. But we'd like to provide like a hotline as well for GPs and other health professionals who could ring CHI with just general queries.
Yeah.
Now we do that every day, but via email but there's no specific hotline. So I think being able to expand a digital offering would be really useful. It would be helpful.
And it's another touch point.
And it augments what's there. It's never going to replace. I think in COVID, we all experienced some type of telehealth or telemedicine, and it works for some situations and it can be really useful for some families. It never replaces in-person paediatric care, but it can certainly optimize it or help it or augment it, I think.
That's great. I'd like to thank Dr. Grace O'Malley for joining me today. To all our listeners, thank you for your continued support and please share this episode. If you would like more information about HSE Health and Wellbeing, follow us on X. Take a look at our HSE Health and Wellbeing YouTube channel or register for our e-zine by emailing healthandwellbeing.communications@hse.ie. This has been the HSE Talking Health and Wellbeing podcast. Thank you for listening.